Good evening, everyone. Myself Santosh, your mentor for StudyMEDIC. So today we'll discuss about status epilepticus adult management. Basically, it's an important aspect of OSCE station. It is commonly asked in of your OSCE research station when you follow the routine ALS protocol and your status epilepticus protocol. We'll go through that. So what is status epilepticus? Status epilepticus seizure which long lasts about for more than 5 minutes. So what we need to know, you need to know the common cause of status epilepticus. Why? Because whenever you end up in your OSCE station, at the end of that, you will be giving the clinical reasoning to your mentor, examiner at that time. For that, you should know the differential diagnosis. Then only you can have a good scoring in your OSCE station. And apart from this, your OSCE presentation, what is important in your status epilepticus management, other than the treatment, what you're giving is documentation, which is very important. So each and every minute is important. So whatever you do, you document your initial assessment. And important aspect is like other from the apart from management, it has got more commonly prone for getting complications because each and every minute is important. Even if you delay treatment or patient is not getting managed properly in ER, patient can have complications like that, airway obstructions, cardiac arrhythmias can develop during patient having seizures, aspiration, pulmonary edema, hypoxic injury to the brain can happen, hypertension, DIC, and respiratory depression. These are the common complications that can happen during management of a seizure activity. Usually you follow a few guidelines which I will be showing in your next slides. That will be nice guidelines and the RKM guidelines also. We'll be coming to that, which where we'll discuss deeply about the steps of the drugs which we are using and when to use the drugs. Epilepsy can occur at any age, but the commonly diagnosed between the age of less than 20 and over 65 year of age. And what is the main goal of your this management is to terminate the seizure and routinely following your rapid ABCD assessment as per your ALS protocol. That is more important. Now I'll discuss in detail about the algorithm. Now this is the algorithm which you have to follow in any of your OSCE station. You get the station and any patient has been given, and this will is the first adult patient. Then I'll focus about slightly pediatric patient also. And this is how you have to go through your orchestration. So as when you have got the patient and timer is on, patient is having seizure activity, whatever history the examiner has given you. Now the patient is you in the ER with you. So what you will do, you'll assess the airway, breathing circulation of the patient, start high flow oxygen to each and every patient. And if required, you maintain a lateral position so that the patient would aspirate, get a wide bore IV cannula. As soon as you get the IV bore cannula, you should take samples so as to rule out the causes of seizure. And then you check the capillary blood sugar. This is much more important in the initial 5 minutes of time. In case if the glucose is less than 4 millimole per liter, in that case we'll start with 150 to 200 ml of 10% glucose IV bolus over 5 to 10 minutes. And then if the seizure continues, despite of giving this bolus dose, you can continue with the 10% glucose infusion also at the rate of 100 ml per hour. Now, as a part of your initial assessment, you will check for attached monitors. You will check for the saturation levels, heart rate, blood pressure, and the ECG. Now, usually, if the time duration has been 5 minutes, usually the seizure has not settled, then usually it will not settle so spontaneously. Now, this is the time after 5 minutes you have to intervene with the intravenous drugs. So now in the station as you goes here, now if it's 5 minutes have happened, if the examiner tells you the time, it's okay. If it don't tell you, you have to ask how much time has happened. Now, if 5 minutes have happened, patient is still seizing. In that case, when the first line of drug is lorazepam, that you can use as a dose of 0.1 mg per kg, maximum is 4 mg. Other drug is diazepam, that is 0.2 mg per kg, maximum is 10 mg. And in case in many of your scenario, examiner might confuse you. He will tell you, okay, you are not able to get IV. Like what you will do in that case? So in that case, what to answer? Okay, you can give sir patient को 10 mg midazolam IM or diazepam can also be given 10 mg per rectal dose पे. Okay, then even within 5 minutes में, if patient seizes again, even after giving this first line of treatment, then you can repeat the dose of the same lorazepam or diazepam. Now, after 5 to 15 minutes, still patient is seizing. Now, this is the important crucial time. Now, this is the time where you have to escalate the matter to the intensivist and your ICU team. You have to inform them team also. What is important in this case, mean you are managing these things in that case, you should be thinking about the causes of seizure also, if you get time. Now this is 50 minutes over. Now after 50 minutes, patient is still seizing. In that case, the second line of drug is anti-epileptic. You have to give anti-epileptic drugs. So anti-epileptic drugs, we have many options. The best is the lorazepam, levetiracetam. levetiracetam, because this is the drug which has got less complication as compared to other drugs, where it has got lesser drug interaction, so it is quite safer. The dose we can use is 60 mg per kg, so maximum is 4.5 gram you can use. You have to dilute 100 ml and given over 10 minutes. If Livera is not available, in that case we have to use phenytoin 20 mg per kg, maximum is 2 gram you can give. But while giving phenytoin, you have to be very careful. It has to be very slowly, because the patient, if you give phenytoin, the patients are being prone for developing bradycardia and asystole, especially in the pediatric age group. So ECG monitoring is important while giving phenytoin. And the last option is valproate. But while giving valproate, you have to be careful. You have to avoid valproate in case of pregnancy, liver failure patients, and the pancreatitis patients, if it is known case of this. So you can use any of this one of the epileptic after 15 minutes. Now imagine 15 minutes has been over and you are less than 30 minutes as patient is still seizing. In that case, you can repeat one of the anti-epileptic which you have not used previously. Clear? Okay, now what happens now? You are at 30 minutes. After 30 minutes, you have given this drug, still patient is seizing. Then now you diagnose your patient to be in refractory status epilepticus. So when do we call refractory status epilepticus? When the generalized seizure duration is more than 30 minutes, and despite giving 2 doses of benzodiazepine, which I have told previously, lorazepam or diazepam, and at least 1 dose of antiepileptic, still patient is seizing. The now patient has been diagnosed as a refractory status epilepticus. Now this is very important. Now in this case, you have to take care of the patient's airway also, because this is the time when you are going to give more drug. What is your third action of plan, that is third line of treatment? In that case, securing airway is very important. So you make sure you, whatever you do, you keep your anesthesia and the ICU team in your loop, and you secure the airway before giving this drugs in the case. So what are the third line of drugs are? Propofol can be given at 1 mg per kg dose. Midazolam 0.1 mg per kg dose can be given. Thiopentol 3 to 5 mg per kg can be given, and ketamine 1 mg per kg dose can be given. Now, after giving this inducing duration, they have to maintain with the maintenance dose of infusion, like propofol infusion and midazolam infusion can be given. But what I have told, make sure patient has to be put on ventilators. So you have to think of securing airway also. Now, what happens is usually in your OSCE station, they will give you a scenario of difficult airway. So you have to adapt in that case. No, sir, I will keep everything by like difficult airway trolley ready. You have to keep your boozy ready. You have to keep your visualiscope ready. And you have to keep informing anesthesia prior intubation also. That is the thing important, because they want you to focus on the airway if you are in the third line of management, which is very important. So don't forget this. So now what happens? You are about in the stage of refractory seizure, and still even 1 hour ho gaya, and you have the seizure has not been settled. Now this is the time where you have to check the levels for the AD levels. Whatever the drugs you have used, their level need to be checked, and what we can do, you can give the repeat bolus dose of the propofol or midazolam as we have given in the previously planned treatment. And even after giving this bolus dose, also patient is still seizing. In that case, you have to continue the infusion dose, and you have to inform the neuro ICU team. Now, this is the scenario when patient is 24 hours, still patient is having seizure, even after giving this many drugs, then you diagnose the patient to be in super refractory status epilepticus. But for the exam point of view, examiner, usually your OSCE station will never go till this stage, but for your knowledge basis, you should be knowing for your day-to-day practices, if the patient is in super refractory status epilepticus, this patient has to be managed only in the neuro intensive care team. Okay, not by in the ER. Now, imagine your scenario, what you have been given, the scenario has been settled, so that the examiner gives you the option, okay, the seizure has been settled. So status epilepticus is settled. Now, what you will do in that case with that? So in that case, again, your role is important. Again, you follow the LS protocol, you check for the ABC. You can go to ABCD protocol again, and then you have to check for the airway within circulation, and then assess the GCS. Most of the time, after giving this many drugs, like if you have not given the plan 3 drugs, GCS portion can come out of the post-ictal state. But if patient is not coming out of the post-ictal state, in that case, if you have to secure the airway, if you have not secured still now, and then you have to look for the focal recall deficit. And if it is required, the neuroimaging is very important in such cases. And if the seizure has been settled after giving you first and the second line of drugs, in that case, if you are planning to admit the patient, don't forget to tell to the examiner that you will continue the anti-epileptic doses what you have given in their maintenance doses, that is usually 5 mg per kg twice BD doses that can be given after admitting the patient in the critical care area. So this was the protocol for your this. adult seizure protocol. It is quite complicated. I have shown you 3 slides, but whatever I have told, if you remember 70% also of this, and which drug, first line, second line, third line also, and securing difficult airway, you will easily score 8 out of the 10 marks. And giving the clinical reasoning very properly. Make sure while you give the clinical reasoning, you should be talking about the differential diagnosis also. Okay, what is the power diagnosis of the patient depending on the history, what the examiner gave you. Okay. So now just what we will do, we will also see the RKM guidelines. These are the recent RKM guidelines for 2025, but this is for the pediatric. So just for your increasing this station was only for the adult station, but I have tried to put the pediatric also so that you compare both the things, and it will be easy for you to remember so that you don't miss, because both the things are same only. Just we'll try to see if something we are missing in the previous thing, So when the season started, everything which we have told previously, ABC will do, check sugar, and try to look for the causes of the seizure activity, which I have told previously. We will send the samples. And after 5 minutes, we will start intervening with the drugs. So we have already spoken. We will give drugs like midazolam, diazepam. And after 10 minutes, you can repeat the dose of the midazolam, diazepam, lorazepam, midazolam. It is the same thing which I have told previously. As I have told previously, after 15 minutes, we were in the adults last algorithm. I have told you after 15 minutes, it is the time and you will start using your anti-epileptic. So here also pediatric also same thing. It is 15 minutes, still child is seizing. Then you will use the safer drug is levetiracetam. If you are not available, Libera is not available, in that case, you will use phenytoin, phenobarbital, or valproic acid. Now, phenobarbital can be used in the pediatric age group with a dose of 20 mg per kg. Okay, now once you have 20 minutes is over, still patient is seizing. Now this is the time when you inform the anesthesia person and the pediatric ICU person, as I have told in the adult station also. Now this is the time you would think of securing the airway before starting the third line of agent. So what are the third line of agent which I have told previously, also I will repeat again. So emergency anesthesia drugs that can be used is ketamine, thiopentol, propofol, and the midazolam. And while doing this, you have to thinking of the securing the airway also. So anything we are missing in this, you can go through the slides also, which I have put here. Now many students are there, they are not okay with this algorithm. So what I have done, I try to simplify the things, same thing in a tabular form. So you can go through this also. This is the same thing which I have told for the both adult and the pediatric. It is the same thing. One thing I want to focus on the dosing. So when you are managing the patient with refractory seizure, so I'll repeat the dosing for you to be remember. Propofol 1 to 2 mg per kg bolus can be given, and after giving the bolus, if you want to start the infusion of the propofol, it can be started at the dose of 2 to 10 mg per kg per hour. That can be titrated as and when required. Midazolam, as I have told, 0.1 mg per kg bolus can be given, followed by 0.05 to 0.5 mg per kg per hour infusion. At times, you have to be very particular with the doses also infusion. The examiner can ask you this thing. Thiopentol, I have told previously, 3 to 5 mg per kg bolus. After that, infusion can be started with to 3 to 5 mg per kg per hour infusion doses also. And don't forget to secure airway, and just don't forget to talk about your difficult airway also during this. So this is all for today's session. If you guys have any doubt regarding any the seizure management, you can approach us any time. We are always available as a mentor at StudyMEDIC. Thank you.